Good afternoon, I'm Rich McKeon. Welcome to our Fast Break webinar series. We're grateful to our co-hosts, the David Eccles School of Business at the University of Utah and the Green Templeton College at the University of Oxford. We appreciate too our contributing sponsors, Intermountain Healthcare, Select Health, J.P. Morgan, and Levitt Partners. We want to recognize our Value-Based Healthcare Symposium scheduled for May 12th and 13th. This will be an online virtual symposium, reduced in scope, but the prelude to an annual symposium that will have a discussion throughout the year on the evolution of value-based healthcare. Today we are grateful to recognize with us Dr. Julie Gerberding. Dr. Gerberding is the Chief Patient Officer and the Executive VP at Merck, but importantly in her background as well, she was the Director of the Centers for Disease Control and Prevention from 2002 to 2009, where she was a colleague of mine and a very valued friend. So welcome, Dr. Gerberding. Julie, we have titled this along the lines of the lessons and impacts learned from pandemic and the COVID-19 experience. And I wonder if we could start a discussion by kind of reflecting from your perspective on how that has impacted a number of different areas. So let's kind of start with patients. How do you see patients being impacted by, and what have we learned from the COVID-19 experience?
Well, one of the, I think, really worrisome things about this pandemic, which of course isn't over yet, is the fact that all patients, regardless of whether they are COVID patients or people with any other medical condition, have been affected simply because they're either told to stay home and have trouble accessing care, or because they're ill and need services in a health environment that in many cases is crowded or sometimes in crisis. So this has really set us back in common primary care areas like screening for cancer or getting your influenza vaccine. We can do a lot of things with telehealth, and that's been one of the marvelous innovations that's been accelerated by the pandemic, but you can't get a mammogram by telehealth. So I think we're going to catch up to that deficit with a lot of delayed diagnoses and probably some people with chronic care that is not well managed.
And that therefore has an impact on healthcare systems as well. Have you thought about how the systems themselves are dealing with this?
You know, one of the amazing things, even at the peak last late winter, early spring, was the innovation that occurred in our health systems as they struggled to cope. We saw healthcare workers coming up with all sorts of workarounds to compensate for the lack of PPE. But even in intensive care units, I spoke to a CEO of a very prestigious hospital in New York City over a weekend, and he was so proud that the team there had figured out how they could ventilate two patients on the same ventilator safely and without any infection transmission risks. So, you know, this kind of, you know, fly-by-night innovation saved a lot of lives, and I think that's built some confidence in the system that we don't ever want to have to be back in that state, but if we had to get there, we do have enough human resilience to be able to solve some of the most difficult problems. I think the other area that we're better prepared for now is the fact that when we had to surge and learn how to open up convention center floors or ancillary care facilities, the planning and the work and the effort that went into that is reproducible, I think, in an easier timeline if we have to do it again than we experienced it in the first go-around. These are not the kinds of things I look forward to. I hope we can keep the curve flat enough to avoid that surge impact, but we do have to keep in the back of our minds that we're just coming into the winter and we could be seeing a lot more respiratory illness and a lot more hospitalization from either influenza or SARS or the combination of them.
So, you know, I love this notion of innovation being a product of this, and it's really, I think we've seen that at many, many different levels as people have done that. We talk about public health. It seems like this is Public Health Day, and you're a big advocate of public health. But this has really risen to the occasion, I think, in many respects. But I value your thoughts on the impact that this has had on public health and its acceleration as a recognized part of the healthcare community.
You know, one of the most important learnings for me when I went to the CDC and served as the director is that public health is not in Atlanta. Public health is in the front line of communities all across our country and around the world. And so what really has been going on in the context of this pandemic at the local level is some incredibly busy and smart people are stepping up. They're also innovating, but they're also working 24/7 to try to do very difficult public health tasks, essential tasks, but at a scale that's basically unprecedented. So just think about the complexities of tracing contacts, so someone with COVID, and then if you're in a community where you have 1,000 people like that, you just simply don't have the human workforce to be able to pull that off. So I think the front line of our public health entities has really been pushed to the front, but they also are now much more visible at the community level than they normally probably have been. It takes a crisis sometimes to reveal the value of your public health system, and they can become heroes overnight when you have a crisis. The rest of the time, often they fade into the background and nobody notices them until the next bad thing happens.
And we'll speculate down the road as to whether or not that could happen again, and I suspect we believe that it could. But talk a little bit, one of the things that we've been curious about is the kind of the movement that has been underway towards value-based healthcare. This idea of outcome-oriented and risk-based payment systems that would be taken on by the healthcare systems. Do you see what we've seen with regards to the pandemic and other things as an accelerant to value or a decelerant to it, and maybe an opening to other kinds of systemic changes?
Well, I thought you were going to ask a slightly different question, so I'll answer the different question first and then maybe come back to the thing you're trying to drive at.
Yeah, that's right.
I actually think there could be an opportunity here to get our heads around the notion of value-based public health. In other words, the current methodology sort of relies on large block grants of resources coming out from the CDC to support certain kinds of categorical public health programs, supplemented, of course, by the state and the city in some cases to the extent possible. But that kind of categorical funding is not really outcomes-based. So you could imagine moving into an environment where the criteria for success were agreed upon by the frontline stakeholders who have to understand what citizens really need and what success looks like, and that the support for that becomes more like a value-based system, where you're really providing the support and rewarding people for continuously improving their public health capabilities rather than just creating, a more of a block grant kind of scenario. So I don't know whether we're ready for that notion. There's some challenges with it. I'm not necessarily advocating that it be adopted wholesale, but serious attention to what are the results of our public health investment that matter to the communities where we're investing, and are we really accountable for getting all of the critical components optimized in a sufficient manner to be able to support the people. And then you bring something, dramatic like a pandemic into this circumstance. And of course, that's a different set of metrics, but an even more critical set to document. If you recall, when we were working on this in influenza preparedness days, that was one of the things that we were really trying to drive for, not just what activities are being done, but what capability can we demonstrate has been improved because of the time and the exercise and the investments that we made. But if you turn that back around to value-based healthcare, I think I've personally been a bit surprised that it hasn't moved forward more rapidly. I thought it would go a bit faster than it seems to have gone, and we're sort of in this bizarre blended world right now, which for many integrated systems or providers, it's actually difficult to practice when you're have one foot in one camp and one foot in the other, and you're trying to make your service model work that way. So I think the pandemic will be a clarifying function, but in the short run, it's causing such financial hardships to so many providers and so many systems that I also suspect there'll be a lot of reorganization, potentially mergers and consolidations that are going to be an inevitable consequence of what's going on right now, just as a practical matter.
I think that's right. And the whole notion that during this period of time, it seems to me that those who were at risk and who were taking care of the health of people maybe did better than those who were at fee-for-service, who were dependent upon that. So, and I appreciate your answering the question that I didn't ask, because it was a better question than I did ask. So thank you. You've dealt with vaccines a lot, but you've also been a real advocate of public-private collaboration and partnerships and the like. And we'd like to explore kind of the status of this vaccine development for COVID right now in terms of where we are, what the realistic expectations are as a consequence of that as well.
You know, one of the smart investments that I think we made in the United States a number of years ago was our investment in BARDA, the entity within the Department of Health and Human Services that was charged with developing countermeasures for terrorism and serious infectious disease threats, so that before something happened, we had a supply of countermeasures available to mitigate the harm that such an event might cause. So that model of BARDA really is a private-public model. Certainly the government is not creating the countermeasures. The government is setting the criteria for the target product profiles and then initiating an incentive system for small and large companies to participate in innovating around those requirements. I think that mindset is one that is going to continue to evolve as we do the after-action reviews in the context of this pandemic. In between the creation of BARDA and where we are today, of course, there was also the creation of something called CEPI, the Coalition for Epidemic Preparedness Innovation, which is an even broader private-public partnership that involves resources from governments, from nonprofit organizations like the Wellcome Trust and the Gates Foundation, and the private sector. And CEPI has as its primary mission developing anti-infective countermeasures through stage 2B of development, which means before they go into the trials that would be necessary to have them formally approved by the FDA, but at a state where their basic safety and toxicity is reasonably known, and they can be metaphorically pulled out of the freezer and implemented at the beginning of the emergence of whatever that threat is. Of course, right now that depends on having a good imagination about what the next threat might be. And we can't have a countermeasure in the freezer for everything. So there's been some choices made. While CEPI was investing in coronaviruses, they were not investing in this particular one because we didn't know about this one. So that leads to the whole next layer that I think will be in our future. And that's much more emphasis on platform development, where we may not have the exact countermeasure for this coronavirus, but we have a platform that can easily be adapted to the next coronavirus that emerges and really accelerate our ability to get vaccines or antivirals available to people much more quickly than we're able to do now. And even now is an unprecedented time frame, but I think we'll, as we've seen, we would be in a lot better shape if we could bring these things forward immediately or within, say, a 3-month period of time instead of a 1-year period of time.
So you spent a lot of time as director assessing people's reluctance to vaccinate themselves on the regular flu and trying to encourage that inoculation process. What did that teach you about? When you read presently that the polls have migrated a bit over time, but I think the most recent one I read said that about 52% of people presently said they would accept a vaccine and 48% said no. How are we going to encourage people to have the confidence to move forward with this vaccine, which will be the thing which will change the nature of this pandemic?
You're right. I have really spent a lot of time thinking about this, even when I was the president of Merck Vaccines, because it seems to me, as an infectious disease doctor who understands the vast amount of testing and assessment that goes into manufacturing and distributing a vaccine, that it doesn't seem rational to me that there is so much discomfort. But when you study the history of medicine, and particularly the history of vaccination, you learn that every single vaccine that's ever been invented was accompanied by some degree of reluctance or controversy. So it's just part of the culture of introducing a new medicine that people don't always understand and may not feel they need because they don't recognize their personal risk. Now, in the current environment, we've got another really huge challenge, and that is that we are intentionally hurrying up the process of vaccine development. So on the one hand, we're promising the fastest possible timeline, and on the other hand, we're acknowledging that we cannot take any safety shortcuts. But I'm not sure people are hearing that latter point. I think they're watching us race to get vaccines and antivirals available, and they're frightened that there may be unexpected side effects. And that's not entirely irrational, because other times in our past, when government has raced to produce the vaccine for an emergency or an anticipated emergency, there have been safety issues. So we, as an industry, got together, the large manufacturers, and said, we sign a pledge that says we will not take safety shortcuts, and we will stick together on this and make sure that we follow all of the FDA guidance for approval, because it's not just a question of people's confidence in the pandemic vaccine. If a mistake is made, or if an unexpected side effect emerges in this very visible and worrisome situation, it will affect our ability to protect children and adults from a whole array of infectious diseases going forward. So the risks are incredibly high, and we feel very, very strongly that safety has to be one of the highest priorities in our overall clinical assessment. But our public doesn't necessarily know that, and if they hear us, they don't necessarily believe us. So that's where the issue of transparency and full disclosure about what we do know and what we don't know. I'm sure there will be side effects from any vaccine that's produced. That's an inevitable consequence of immunization to some extent. But I think acknowledging what we expect, how we manage it, how serious it is, and continuing to learn as we go is going to be absolutely critical. The other thing we need, candidly, is trusted voices providing that perspective and context so that people can have a resource that they really do trust. They don't have to depend on their Facebook page for information, or from a politician who might not have the full scientific picture, but that we really work hard to identify trusted people who can assess the science and deliver the message. I'm really counting on the CDC Immunization Advisory Committee for this, as well as the National Academy of Medicine. Those are two places that I certainly have high trust in, and I'm hoping that that will prove to be something that at least Americans come to trust as a credible resource.
You seem to be inferring that the timeline it could be really quite short in terms of our time. Historically, our timeline is going to be short in the development of this vaccine, but how realistically do you see this thing rolling out now, from now through manufacture, distribution, and the like?
Well, clearly this is a big conversation and a big controversy. As a scientist who understands all the things that can happen when you're developing even the most promising vaccine, I'm not placing any bets on timing. I think that because of the requirement for a full safety assessment, and the fact that the trials can only go as fast as people in the trials develop exposure and you can determine the benefit of the vaccine, that's unpredictable. You can speed it up by enrolling more people or doing the studies in places where the risk is higher. But at the same time, you're encouraging people to enroll in your trial. You ought to also be telling them how to protect themselves so that they don't inadvertently increase their risk. And all these things are unknown. So while I'd like to agree with Dr. Fauci and say that I think we will have a population relevant vaccine sometime next year. I really certainly wouldn't promise that, and I hope it's sooner. I hope we get something for healthcare workers on an emergency use platform, or something that can help our most vulnerable people on a global basis sooner than that. But in terms of when is it going to mean we can go back to work and school as normal, I think it's going to be quite a while.
Let me, that's really helpful. You testified recently before Congress. You've done it many, many times before, but I think on June 23rd, you testified before the Senate Help Committee on issues related to preparedness predominantly. And I know that you're associated with the Center for Strategic International Studies and their Commission on Health Security. Just can you encapsulate the things that both we have learned, but the things that we should be doing now to prepare for other biologic events? And I think they're inevitable. You believe that, I do. We've experienced that on multiple occasions now. But what lessons have you learned about what we should be doing in anticipation?
You know, the CSIS commission that I co-chair on global health security published its recommendations in November, just before the SARS-CoV-2 virus emerged, just by an unfortunate coincidence. But the recommendations reflected wise input from a lot of people, including a bipartisan set of senators and representatives. I think one of the areas of highest consensus is that we need to think about biopreparedness as one of the strategic pillars of our national defense strategy, that health security really is national security. And in that sense, the way we fund it and invest in it and build up the capacity to be ready, truly ready, in the same way that we try to make sure our defense system is truly ready and then pray we never have to rely on those assets. That's a mind shift that I think we're ready for. And that also means that we need sustained leadership and a strategy that goes beyond the one-year term of the congressional budget or the term of office of an incumbent administration, because it's too important for us going forward to allow these kinds of decisions to wax and wane. When we're in a crisis, we spend a lot of money and we get very excited, and then when the crisis is over, we become complacent and we repurpose the resources in some other direction, so that we never really fulfill the optimal benefit of the planning, the exercising, the countermeasure development, and the hospital and healthcare system evolution that we need to have the confidence, and that people can have the confidence in that, well, we hope we don't have another pandemic virus, but when we do, we're a lot better able to protect our citizens. That's what we need to accomplish. And, if we haven't learned that lesson in the current context, I fear we're never going to, because I don't think the lesson could be much harsher than we're experiencing right now.
You've been a voice for that for many, many years and even decades now, in terms of the preparedness and the importance of preparing for these biologic events. Julie, thank you so much for taking the time to be with us. It has been just illuminating and helpful, and I think it'll be a great part of the commentary for the group that we're working with. So thanks so much.
Thank you. It's been an interesting conversation, and I really appreciate that you're still there to support the evolution of our biopreparedness. So thank you.
So we're grateful to Dr. Gerberding. We also want to recognize that our next webinar is scheduled for November 12th. That date's a placeholder. We are intending to have two very significant Washington political prognosticators with us, Sarah Singleton and Vince Ventimiglia, who will evaluate the value-based healthcare in terms of the election that has just occurred. And our timing will be dependent a little bit upon when we have election results. We're grateful again to our co-hosts, David Eccles School of Business at the University of Utah, and to the Green Templeton College at the University of Oxford. We once again would remember the symposium, the Global Value-Based Healthcare Symposium, scheduled for May 12 and 13. We thank you for joining us today, and we look forward to our next Fast Break webinar and evaluation of the election results, which we think will be fascinating and relevant to this discussion of value-based healthcare. Thanks so much.